everybody, Dr. Ryan here. I'm a board certified specialist physician. Thank you so much for joining me even as we look at a clinical approach to a patient who has a problem of ptosis. If you haven't yet subscribed to my channel, I strongly encourage you to smash that subscribe button and like and share. Alright, so ptosis refers to essentially drooping of one of your eyelids. We'll have a look at a picture shortly. But I mean, the way you're going to approach this problem, this is a mind map. So from a conceptual perspective, is ptosis unilateral affecting one eyelid, or is it bilateral affecting both eyelids? So let's look at unilateral ptosis, right? Then you've got to ask yourself, is there an ipsilateral pupillary abnormality? So if you're dealing with a situation of partial ptosis and pupillary constriction, this is Horner syndrome. Horner syndrome is a triad of ptosis, meiosis, and anhidrosis. All right, and it speaks specifically to a lung cancer, like a superior sulcus tumor or a Pancoast tumor, with involvement of the cervical sympathetics on that side. And the result is ipsilateral anhidrosis, enophthalmos, clubbing, and hand wasting. Right? Or ask yourself, is there marked ptosis with pupillary dilation? So either the pupils are constricted or dilated. If they dilated, you're thinking of a third nerve palsy. And usually this keeps company with either a cavernous sinus lesion or raised intracranial pressure, right? But if you're dealing with bilateral ptosis, you've got to ask yourself, is there accompanying bilateral facial weakness, right? And if there is concomitant frontal baldness and aphakia, which is the mandates the use of thick glasses, wasted sternomastoids, you're probably dealing with myotonic dystrophy. This often gives you neck flexion weakness, right? But if you've got fatigability, where the muscle weakness is typically worse later on in the day, together with a bulbar palsy, you're thinking about myasthenia gravis. So that's a nice way to approach ptosis, okay? The first departure point is it unilateral or bilateral? If it's unilateral, is there also a pupillary abnormality? If there's meiosis together with ptosis and anhidrosis, you're thinking about lung cancer and a Horner syndrome with invasion of the cervical sympathetics. But if there is, pupillary dilation with marked ptosis, thinking of third nerve palsy, you want to do a CT brain to look for raised intracranial pressure. You want to look at the cavernous sinus if there's accompanying lesions of cranial nerves in that area, right? But if there's bilateral ptosis, ask yourself if there's bilateral facial weakness. If you've got features of myotonic dystrophy, there you go. But if you've got fatigability with bulbar palsy, you're thinking more along the lines of myasthenia gravis. Alrighty, so here looking at the eye muscles and nerve innervation. So you know the acronym there is SO4 LR6 R3. So the superior oblique, and the function of the superior oblique is to intort the eye, to look down and in. And that's taken by the fourth nerve. SO4 LR6 is lateral rectus, the sixth nerve. That's responsible for abducting the eye. And the rest of the eye move is taken by the third nerve, right? So if there's a lesion of the third nerve, it will present with ptosis, usually complete ptosis, right, together with dilation of the pupil, right? We have ptosis, dilation of the pupil, drooping of the eyelid, which is essentially ptosis, right? Together with diplopia and divergent squint. Those are the 4 Ds of a third nerve palsy. Here's a patient typically with myasthenia gravis who is manifesting here with bilateral ptosis, as you can see. And the key thing about myasthenia gravis is that it affects neuromuscular junction, and the key word we talk about is fatigability. So you find the ptosis is worse towards the end of the day. A couple of tests you can do: ask the patient to look up, to keep looking up, and eventually you'll see ptosis. And you can do the ice pack test and the tensilon test, and the patient will present with a myasthenic snarl. And for more information on that, have a look at my video on myasthenia. All right, here is Horner syndrome, as we can see. So in Horner syndrome, typically the ptosis that we have is not complete, right? It's a partial ptosis, and it's accompanied by meiosis, right? So there's pupillary constriction on that side and anhidrosis, together with enophthalmos, right? So important causes of ptosis, so this is taken from Talley and O'Connor. Let's just quickly have a look at this, right? So it could be age-related stretching of the levator muscle and aponeurosis, which is common and often asymmetrical. That's a tip-off. An orbital tumor or inflammation will give you an orbital abnormality as well. Constricted pupil with reduced sweating, ptosis, meiosis, anhidrosis, enophthalmos, Horner syndrome, which is invasion of the cervical sympathetics on that side by a lung cancer. If the eye is down and out, you've got a dilated pupil, patient complains of diplopia, that's a third nerve palsy. Myasthenia gravis or dystropia myotonica, especially if there's other accompanying extraocular muscle palsies, muscle weakness. It could be a congenital or idiopathic variant. Okay, this is another way of looking at ptosis is by the acronym tensilon me doc. right? T for third nerve palsy, E for eye drops, then we have steroids, N for neuromuscular junction disease, especially myasthenia, not so much Eden-Lambert. S is surgery, I is infection, then we have herpes zoster ophthalmicus, watch for the Hutchinson sign at the tip of the nose. L is lid infiltration by tumor or inflammatory tissue. O is oculosympathetic palsy, being Horner's. N is neurotoxins, then we have botulism. M is myopathy, and then we have muscle dystrophy or myotonic dystrophy, right? That's the typical diagnostic phases. And ophthalmos refers to eyelid retraction into the orbit. D is diabetes or thyroid disease. Remember, diabetes also causes the isolated third nerve palsy, and which is pupillary sparing. A is opposite lid retraction. C is for cluster headache. All right, that's essentially that. Okay, my friends, the book of James chapter 4 verse 14 says, "Why? You do not even know what will happen tomorrow. What is your life? You are a vapor or a mist that appears for a little while and then vanishes." Jesus said, "Do not store up treasures for yourself on earth where rust and moth corrode and thieves break in and steal. Rather store for yourself treasures in heaven." Right? Paul would also say that whatever is seen is temporary, but what is unseen is eternal. Beloved, let us set our heart and mind on things above. Let us always live with eternity in mind. Right? Because it is eternity what counts and not just this life on earth. I pray this upon you. Here are my references, guys. Thank you so much for joining me. I'll see you soon with another helpful video in this series. God bless you.